Good afternoon, everyone. I'm Arun Joseph, and I'm a graduate reading for DPhil in Clinical Neurosciences at University of Oxford at Jesus College. And my broader research question is how we can get patients safely off the ventilators after a traumatic brain injury. I'm also an assistant professor in physiotherapy at Coventry University. I'm also the founder of Ventilator Weaning and Extubation in Neurocritical Care Network, which is supported by Nuffield Department of Clinical Neurosciences. I thank Jacqueline Pumphrey from NDCN, who's our public engagement and communications manager, who's there here with us today for helping us set up this network and also for organizing this event. So our network aims to bring together an interprofessional team who are interested in ventilator weaning and extubation in neurocritical care. And through this network, we aim to conduct interprofessional and interdisciplinary evidence-based projects, hold regular lectures and seminars which are pertinent to current trends and state of the art, and also identify research priorities based on clinical practice and integrate cutting-edge neuroscience to answer some of the difficult questions in this area. So today's lecture is on role of physiotherapist in weaning and extubation after brain injury, and our speaker is Ms. Janis Harvey. Janis is a consultant physiotherapist working in the southeast of Scotland Major Trauma Centre at the Royal Infirmary of Edinburgh. And with over 20 years of clinical experience in neurocritical care, Janis is also actively involved in the Scottish Surgical and Critical Care Physiotherapy Practice Development Network. She's also an associate lecturer at Queen Margaret University in Edinburgh, and her research to date has focused mainly on effect of respiratory physiotherapy on intracranial variables. So a warm welcome to you, Janis, and over to you.
Thanks, Aaron. I'm just going to share my screen.
Thank you.
So thank you, Aaron, for such a lovely welcome and introduction, and to the network for inviting me here today, and to all of you for joining, which is probably over your lunch break. So hopefully you'll find what I've got to share with you today interesting and informative. As Aaron's already said, working in the Southeast Trauma Network of this part of the Scottish Trauma Network here in NHS Lothian. We opened our major trauma centre in August 21, which is a combined adult and paediatric centre. We have a 42-bed general ICU, and within that, we look after our neurotrauma patients. This is a sky view of the site itself with our new buildings, which are recently opened, and beyond in the distance is the nicer view of the castle, and it's been chopped out of this. So what I'd like to do over the next 45 minutes or so is just to have a look at the role of the physiotherapist and the input that we have for these traumatic brain injured patients throughout their journey in critical care. Thinking about the period when they have their ICP monitoring in, when we move into weaning, those patients that move on to having tracheostomies, and ultimately what our rehab for those patients are throughout that time. I don't have anything to declare other than this will be a brief overview, and it's literally based on my experience working with this patient group, and that local experience hopefully backed up with some literature as we go along, but we'll welcome opportunity at the end to compare what other practices people have and how that differs or is similar to what we do here in Edinburgh. So as a brief overview, we know that respiratory dysfunction is common after severe traumatic brain injury, with an incidence of VAP about 36%. And we know that that's because these patients need intubation, they need sedated and or paralysed, and that all have an effect on their cough. Because of altered GCS at the time of injury, they often are susceptible to aspiration, also potentially have chest trauma as part of their injuries list, and because of all of these things often are unable to be repositioned as often as we would like. This can lead to compromised gas exchange, predominantly due to reduced lung volume and secretion retention. So for respiratory physiotherapy for this patient group, I mean, in general, physiotherapy is accepted as part of the general management for these patients, and respiratory treatments are in the main looking at achieving TBI gas exchange targets. And our treatment options are as follows, but aren't limited to: positioning, bagging, suctioning, the use of manual techniques, and optimizing humidification and hydration. But the evidence for this area of physio practice is limited, and looked at this, as Aaron said, as part of a research for M-level studies, and a lot of this evidence is dated. It's not been conducted within the UK. It doesn't reflect our current practice, and often they're combined treatments that have been used, so it's hard to know which has been effective, or if they haven't, or if they've had a detrimental effect, which one actually caused the problem. As we know, traumatic brain injured patients are managed with a protocolized bundle of care, and I'm not going to go through all of the elements of that, but physiotherapy can influence certain aspects of this bundle. Predominantly, we're going to consider the impact that raised CO2, its effect on intracranial pressure, that plus or minus altered oxygenation can both have a negative impact on intracranial pressure. CO2 due to increased CO2 due to vasodilation, and hypoxia due to the impact that then has on the changes in cerebral blood flow, which occur to try and improve delivery, which then has an impact on intracranial pressure. So locally, I would go through this sort of stepwise approach, thinking about if intracranial pressure is raised, is it due to respiratory compromise? Is it due to altered CO2 or O2, or is it actually just due to increased intracranial volume? Thinking about CPP, not because that's something that we necessarily can influence directly, but if we were to go on to treat patients, particularly with bagging, then there is a potential to impact mean arterial pressure, which could compromise CPP. And we would need to be aware of how we can adapt and change our techniques, or utilize such as noradrenaline to alter MAP to maintain CPP. And then thinking about the two elements that are compromised with gas exchange. If the CO2 is raised, is that influencing the raised intracranial pressure? Both loss of volume and secretion retention can impact the CO2, and they're usually both amenable to physio. Similarly, with hypoxia, we know that that will exacerbate CNS injury. And again, if it's due to secretion retention or loss of volume, we can usually intervene with that. So there does follow then a process of decision making about if the patient, through assessment, we identify that they have respiratory problems and signs of respiratory compromise, what treatment options do we think would be suitable or amenable to treat that? The list of treatment options that were already raised. And then other considerations, is there anything that we need to keep in mind in terms of utilising those options, particularly if they're a trauma patient, if they don't have an isolated head injury? And really the question is, do we have a window of opportunity? If an intervention is indicated, is this the right time to do it in terms of patient stability? So at this point, I'd like to introduce you to a patient that we're going to follow through in their journey. I'm going to introduce you to Tony. He's a 56-year-old male, no significant past medical history other than being a social drinker and a non-smoker. He lives alone, works in the building trade. On this particular fateful night, had been at the pub and had been found at some point later on at the bottom of 18 concrete steps. This fall was unwitnessed and was GCS 3 at the scene. He had an obvious external head injury and initial ambulance input, and was brought to his local trauma unit, where he had imaging, was intubated and ventilated, and then transferred to the local major trauma centre to that trauma unit, where he was admitted to critical care for TBI management. In terms of how we organise our services, you can see in the middle there that across Scotland we have 4 major trauma centres as the squares, and all the other coloured dots which represent trauma units, who will then transfer patients to the MTC. These are Tony's injuries that you can see. So skull fractures, a traumatic brain injury, subdural hematoma, temporal fractures with global edema. He had an ICP bolt, a Lycox inserted, and continued on the TBI management protocol. Facial fractures, spinal injury, which just needed C-spine precautions, lacerations from the fall, and a lung injury in the form of upper lobe atelectasis, probable aspiration, but no rib fractures. These are just a screenshot of his head CT. We can see going from left to right, the swelling from the point of impact. There is a skull fracture, a shallow subdural, and the temporal lobe contusions. So looking at his assessment then, from a physio point of view, we'll go through us on a systematic approach in terms of functions. So from a respiratory point of view on this assessment, Tony was fully ventilated on 50%, but with a rate of 30, an FiO2 of 0.8 for a gas exchange, a CO2 of 5, PO2 of 16. So looking at these numbers, he does have a high respiratory rate, presumably for that CO2 control to keep the CO2 between 4.5 and 5, and a significant amount of oxygen there to keep his PO2 over 13. This, by definition, would be moderate ARDS. His PF with those numbers would be 20. On auscultation and palpation, there are signs there that Tony has reduced lung volume and secretion retention through added sounds on auscultation, palpable secretions. This is his X-ray. At the time, we can see he's got bibasal changes, reduced lung volume, and some opacity through the left side. From a CVS point of view, we've got a bit of noradrenaline running, starting to maybe have a bit of a temperature. The noradrenaline's interesting in terms of moving forward with treatment options that we may need to utilize that should any intervention compromise mean arterial pressure and CPP. From a neurological point of view, his ICP currently is well under the target of 20, maintaining his CPP. He is paralysed and sedated at this point, so there's definitely a consideration there around cough effectiveness. He will not cough and has not had any ICP treatment. So from a neuro point of view, starting to consider whether there's an opportunity here to treat the patient. Renally is stable, and at this point when we saw the patient, his C-spine had actually been cleared, which is important for us in terms of suitability for manual techniques and thinking forward about secretion clearance. So if we come back to our stepwise approach for him, his ICP is under target and has had no recent treatments, so there's a potential window for opportunity in treatment. His CPP is achieved and we have the noradrenaline available. From a CO2 point of view, it's just outside the range of 4.5 to 5, which is not impacting his ICP. So we'd be thinking that the CO2 is a little bit high, that if it was causing significant vasodilation, that would cause a rise in ICP, but his is well under target. However, to keep the CO2 within range, we're needing a significant respiratory rate to achieve that, which would imply underlying respiratory compromise. And similarly with PO2, we're achieving that target of over 13, but we're needing a significant amount of oxygen to achieve that. Overall, there are signs of reduced lung volume, of secretion retention, and we probably have a window of opportunity here to treat that compromise. Our treatment options, thinking back to the beginning, thinking about we can utilize manual hyperinflation. We could utilize manual techniques because the C-spine is clear now, and we will need to utilize suction. He has a protected airway and paralysed and sedated, so no other means really to clear secretions. So thinking about bagging specifically then, the main considerations during bagging are the effects on CO2. If we alter the CO2, there will be changes in cerebral blood flow and ultimately potentially changes in ICP. We will utilize the end-tidal CO2 monitoring to try and keep that CO2 in range. So we'll compare the end-tidal CO2 value with the PCO2 from ABG. We know they're not going to be the same, but they are comparable and they correlate. So we can utilize that as a reference range. And during the technique, altering altering the rate and the size of breath that we deliver to have an adequate effect on CO2 to make sure that the patient tolerates it from an ICP point of view, and also keeping an eye on that mean arterial pressure, the impact that increasing intrathoracic pressure can have on venous return may compromise blood pressure and ultimately CPP. Locally, that leads to our next question, which is which equipment are we going to use to deliver this technique? So two main bagging options we have are the C circuit there on the left, which relies on a constant gas flow to have the bag filled enough to deliver a volume. It has the pressure release valve, which is adjustable, allows you to change the size of the breaths, but it is a rebreathe circuit. So whatever volume is delivered through the device to the patient will to an extent come back into the bag and essentially be redelivered with the next breath, which means that there's an element of not being able to control the CO2 because there's always going to be that element of rebreathing. On the right there, though, we have the self-reinflating resuscitation bag, which also has a valve, but it's a one-way valve, a duckbill valve, which means that the flow coming through the bag to the patient is the oxygen through the circuit, but whatever the patient exhales then moves through the one-way valve and is expelled into the atmosphere and does not go back into the bag. So CO2 in effect is eliminated on the exhalation phase, which allows an element of CO2 control. So in preparing to bag the patient, we would start with establishing that reference range as an estimate of CO2, utilising the end tidal monitoring. Select the self-reinflating bag because this particular patient is having ICP monitoring and CO2 control. We'll monitor the end tidal CO2 throughout treatment, adapting technique and maintaining end tidal within the estimated range. And before reconnecting the patient back to the ventilator, if the CO2, end tidal CO2 has gone out with that range, is bringing it back in so that we avoid sudden changes in CO2 and ultimately ICP as a result of altering ventilation going back onto the ventilator. So for Tony in this scenario, we did have signs of secretion retention and loss of volume, which were compromising gas exchange. We went on to bag him with the self-reinflating bag and utilised the expiratory VIBs to his upper zones, and lots of suction and lots of secretions were successfully cleared. He was stable throughout, but there was a bit of modifying in technique to maintain his blood pressure. So as we move out of this ICP monitoring phase, we started to normalise their ABGs, weaning off sedation and moving the patient more into a weaning stage. I want to start now to consider what our input would be at this stage. So on our next assessment of Tony, he has essentially been weaned. He's on to ASB, pressure support of 0, PEEP of 5. His FiO2 is now much significantly less at 0.3 with normalised gases, but still has this secretion load. Things that we need to be contemplating now is he's essentially achieved a spontaneous breathing trial and does have good gas exchange on minimal FiO2, does have a secretion load, so we do need to think about managing that. Should he be extubated, and really having a think about assessing his cough. Is he coughing spontaneously against the ET tube? Will that still occur if that stimulus is removed? Or is he only coughing when is suctioned, which might add even more doubt as to whether he'd protect his airway after extubation? On auscultation, still got altered breath sounds and added sounds, implying that there's still issues with loss of volume and some secretion retention. This is his X-ray though, on the right-hand side now. So we can see we've definitely got an improvement in lung volume, particularly on the right side and to an extent into the left. So the fact that his gas exchange is improving with minimized FiO2 fits this picture. From a cardiovascular point of view now, the noradrenaline is off. Neurologically, just on alfentanil at 2 mils an hour, his GCS is E4, he remains intubated, and an M4. So again, concern about that motor score being so low and being unable to follow commands does add that concern around ability to maintain airway and clear secretions should he be extubated. and nothing new from a renal and MSK point of view. So that leads us on to this thinking around the art of extubation. This is why we're all here. This is why this network is valuable to us. We are all thinking the same questions. When is the patient ready? When are we ready to talk about discussing readiness to extubate? I think for Tony, we're definitely there, past that spontaneous breathing trial, but we've already got lots of queries about whether he'll be ready and what are we going to assess in terms of cough effectiveness, secretion clearance, and the impact that this altered consciousness is going to have on his success at extubation. From a physio point of view, I'm almost always thinking about what are our options post-extubation. So if we go forward with this, what am I going to have in my toolkit in terms of supporting that extubation? Obviously, invasive means in terms of suctioning. Locally, we utilize our E70 in sort of an IPPB birding mode. We also have cough assist devices, thinking about positioning and mobilizing if that's going to be appropriate. And also as a team, what is our level of expectation? When, at what point are we going to say that this extubation has failed? And what is our tolerance of failure? Are we going to be quick to reintubate if secretion load's an issue, agitation's an issue, altered GCS remains an issue? As a team, we need to be clear about that. And certainly from a physio point of view with our invasive techniques, want to be clear about how far are we going to go. And this is raised by Coplin et al. In 2000, who said that clinicians frequently face the dilemma of whether to extubate TBI patients with satisfactory weaning parameters, even though you've got concerns about a level of consciousness and that ability to maintain their airway. And that's exactly what we faced here in this scenario. Looking at the literature, this was a review from 2018, which highlights that these TBI patients are at risk of extubation failure up to about 38%. But it's also not appropriate to wait and delay extubation in the hope that they'll be better. We actually might be putting them more at risk because the longer they stay intubated, the more risk they are of VAP. But there is no strategy about what is the safe process, or nobody's described what that looks like. But predictive scores may be helpful in determining success of extubation, and through this review identified age under 40, whether the patient can achieve visual pursuit of people in their vicinity, the presence of swallow, and effective cough. Similarly, De Silva, recently, this article is in press, looked at predictors of extubation and stratified them into 3 pools. So if you were female over 40, had extended time on a ventilator, and then airway protection factors, a motor score of less than 5, or a GCS total between 8 and 10. Moderate secretion volume requiring regular suction, or weak and absent cough, which could be objectively looked at through peak flow measurements. So this is our $1 million question. If only it was as easy as this one to answer, but this is what we face on a daily basis with these patients, is working together to determine for that patient what is the right course of action. So for Tony, we did have signs of ongoing reduced lung volume and potentially secretion retention. From a physio point of view, we went on to do more bagging, this time now with the C circuit, because there's no ICP monitoring and we had normal CO2 targets. There's more control, I think, in handling the C circuit. You can adapt the technique a bit more, which might facilitate secretion clearance a bit better. Utilised an array of different manual techniques, VIBs, AD holds, rib springing over a number of treatments, obviously ongoing close suction and positioning. And the decision, because of these ongoing respiratory care needs, was not to extubate. He did have a motor score less than 5, he is over 40 and had a moderate secretion load. And the decision was to proceed to tracheostomy, which in all fairness was just as well, because on the day we made that decision, he actually plugged off his ET tube and needed that replaced before tracheostomy. So Although we're not necessarily using any of these predictive tools, it does demonstrate that combined experience does go some way in terms of being able to predict whether somebody is or is not ready to extubate. So from a tracheostomy point of view, looking at early versus late tracheostomy, when we look at this evidence, early tracheostomy is literally that. These papers are relatively recent, and they're talking about early being within days of hospital admission. And it goes without saying, they've shown that it shorter ICU length of stay, lower pneumonia rates, but what we need to consider is whether a patient could tolerate lying flat for a tracheostomy within 5 days. Tony certainly wouldn't have. He was incredibly precarious with his ICP over an extended number of days, and there's no way that he would have tolerated an early tracheostomy. So we do, even though the literature suggests that early, as in within a few days, could help reduce ICU length of stay and pneumonia rates, we're not going to do that at the expense of patient safety. And as this Google search concluded, it's controversial. So again, be interested to hear what happens in your units, but certainly here we're not necessarily, not with TBI patients necessarily doing early tracheostomy. Once we're into the tracheostomy phase of these patients' journeys, we tend to use a variety of adjuncts to facilitate trache weaning. Tony utilised all of these as part of his weaning pathway. We utilised what we would call T or Y piece, so essentially heated humidified oxygen plus or minus a bit of CPAP. And the Y connection, as you can see in the picture there, just allows for closed suction. So those of you who are familiar with working with this patient group, often their secretion load can be significant, and the thought of having to do open suction on a regular basis, the team caring for the patient are generally quite grateful for the opportunity to keep their closed suction device. Passing Muir valves either inline or straight onto the tracheostomy with extending periods of time. We are also keen on Swedish noses in terms of maintaining humidity for patients who are not able as yet to vocalize. And we also utilize the caps as well onto the tracheostomies. Tony, as I say, did actually follow that as a path. I know a lot of patients will go back and forward depending on their progress, but ultimately we'll work towards being capped off for 24 hours before decannulation. So lastly, to think around mobilising patients in critical care. We've talked a lot about the respiratory side of things, but mobilising patients in general ICU is essentially established. There's a lot of literature and research and guidelines out there now which details the safety and feasibility of doing this with critically ill patients. We know it improves functional outcome, it reduces delirium, reduces vent days. But the issues are still ongoing. A Cochrane review in 2018 identified what we all know is that we still don't know what type of exercise, the timing, the intensity. These are the questions that we have. In lieu of that, we will use our best judgment and our clinical decision making to decide. Specifically for critical care patients who've had TBI, the early mobilisation appears to remain controversial. This is a paper from 2020, which says that there's different challenges for these patients than the general population. And in general, they're excluded from a lot of the ICU trials. There's a lack of RCTs mobilising neurocritical care patients, although there's a number which suggest that passive activities are safe. Passive movements, cycle ergometry or motomed, something along those lines appear to be safe. But again, a systematic review of neuro patients also suggests that time, dose, intensity remains poorly defined, but we know that intensive rehab programs do lead to earlier functional ability. Another paper from last year looking at historical concerns about the appropriateness of early mobility in neuro ICU patients, particularly those with impaired consciousness. Goal-directed mobilisation wasn't harmful, but increased the likelihood of functional independence on hospital discharge. So we probably should undertake this for these patients and start as soon as the patient's condition allows. Obviously, it goes without saying that we do need to consider safety criteria, but what is evident for the neuro patient is that where with general patients this activity can happen incredibly early in their stay, that typically for a neuro ICU patient this is going to occur at least 7 days after their brain injury. Locally, I would beg to differ with that, but this is something we can discuss. So this leads us on to how do we risk assess when a patient is ready to mobilise, particularly for neuro ICU. So thinking about an A to F, is the airway secure? That is our main concern for these patients, is airway protection, given that they've got altered consciousness. Locally, by the time we're ready to do more larger scale exercise or activity, they've either been extubated or have a tracheostomy, and that is just our local practice. That's not to say that you couldn't get somebody up with an ET tube, but asking the question of airway security is important. From an exercise response point of view, we need to be sure that from a oxygen need versus demand, if we're going to exercise, what their FiO2 and respiratory rate is doing, and whether the patient is actually ready to exercise. From a cardiovascular point of view, looking at stability, whether the patient still has vasopressor and noradrenaline needs, because again, if we're going to move into more upright position, or if patients have blood pressure targets still, we need to be aware and sure that we can meet those. From a disability point of view, GCS in terms of level of consciousness, are they still on sedation? Typically, if to move on to doing larger scale activity, would tend to have the wait for the patients to be off sedation, but not necessarily off analgesics like alfentanil. What deficits do they have that we need to take into account? Some may not be evident until they're in a position where they have a smaller base of support. What other injuries do we need to take into account, particularly for our major trauma patients that may have long bone or abdominal injuries or surgery that we need to take into account? Seizure activity, whether that is happening or whether that precludes activity from happening. If they have a bone flap, again, particularly if you're going to sit patients on the edge of the bed, thinking about where we're going to put our hands to support the patient, whether they have a bone flap or not is incredibly important. And pain. If the patient can't actually articulate that, keeping an eye on other indicators and signs that the patient could be in pain. From an environment perspective, monitoring and invasive lines, the same for any ICU patient. Locally, typically their ICP bolt is out by this point, but it wouldn't be out of the question if that was still in, to start movement and exercise. If the patients have a drain in, ensuring that that's clamped, and that more importantly, when the activity is over, that it's unclamped. And the practical things, have you got the right amount of people? Do you have the right equipment? And once you get going, what's your plan B? So if you get going and it's not going as you'd hoped, what is your strategy for discontinuing treatment? And another thing under F, I went for fear of the unknown. It's a common theme through the literature that I had a look at, that if there's a culture within a unit of safety concerns, or the staff possibly not feeling comfortable or confident moving or mobilizing this type of patient, it's up to us to make sure that there's clear communication, that we work together and we have a positive experience. So hopefully by going through this risk assessment together, we can reassure each other that we're at the right stage and time in terms of instigating an exercise activity. This is not an exhaustive list by any means, but it's definitely the natural progression that we would go through with our patients. We'd start with passive activity, looking at limb range, positioning, splinting, if that's appropriate. And thinking about that, those papers that said about starting activity after 7 days, I would expect these sorts of passive activities to be happening from admission. We want to maintain range. We want to be sure at that stage, obviously, we're not going to know about tonal changes until sedation comes off, but we definitely have an opportunity to begin to contemplate optimizing from the get-go. As patients start to emerge, looking more at bringing the patient out of bed, either by full body hoist, or we have access to transfer chairs that lie flat and you can pat slide the patient over out of bed. If the patient, as they progress, we would then look to having supported time on the edge of the bed, looking at balance, looking at any deficits, looking at limb strength, whether that level of consciousness changes with activity and engagement. And hopefully that would naturally progress forward into some weight-bearing activity, depending on other injuries, looking at the use of transfer aids or mobility aids to facilitate progression. So coming back to Tony, in terms of his care, he did have passive limb movements and stretching from the get-go and positioning. He naturally moved on to doing some active assisted limb movements. He was full body hoisted up into a chair, attempted bedhead sitting, went on to use a Sarah Steady to facilitate weight bearing and a stand aid, gradually moving on to then handheld assistance for step transfers and progression of mobility. Now, he is managing to mobilize outdoors for up to 20 minutes or so with supervision and no aids. He's safely managing to negotiate steps and curbs and is doing some higher level balance work. He does, however, have ongoing issues with cognition and this sort of lack of insight into how this lack of memory and linguistic issues will impact his life in terms of being able to live independently, and so is having ongoing OT and speech and language input. So in summary, to pull things together, while the patients have their ICP bolt in from a physio point of view, we're looking at signs of respiratory compromise or altered gas exchange. Altered gas exchange, which might be compromising intracranial variables. So we talked about how respiratory issues around CO2 and hypoxia could contribute to raised intracranial pressure. Is there something in there that's amenable to physiotherapy that we can try to affect improving gas exchange so that it doesn't have that negative effect on ICP? We do need to consider whether what we want to do is going to be tolerated. And this is where working together with the MDT and the team around the bed space to make sure that what we would like to do is that everyone's agreeable that that is a sensible decision to make. And ultimately what we're trying to do is reduce those secondary insults related to TBI that are due to changes in gas exchange. As the patients move out of their protocolized care and into a weaning phase, again, using our assessment tools to look at respiratory compromise, but whether that's actually hindering progress. So is a secretion load or a loss of volume actually affecting the ability to wean pressure support or to wean PEEP? And are any of these issues, again, amenable to physiotherapy? We would hope that their sedation is weaning at this point and that we can transition from more passive activities through to more active techniques and engage the patient a bit more. Ultimately, the goal is to support progress with weaning so that we can move forward and ask those questions about whether the patient's got readiness to extubate or whether either having an extubation, whether that's successful, or if there's a failure in extubation, if the patient is to move on to tracheostomy, or whether it's obvious that the patient isn't actually going to progress with weaning without a tracheostomy. For patients with tracheostomy, we would continue our respiratory care in terms of moving forward and progression of trache weaning, looking at formulating and monitoring weaning plans and ongoing respiratory care to facilitate that. And that's certainly something that requires the team involvement, team engagement to make sure that the plans that we're bringing together are actually progressing the patient forward in terms of muscle strength and ability, that we're ultimately looking towards progression to have the patient decannulated, utilising all those different adjuncts that we have in some sort of structured way to make sure that the patient progresses. And then in an overarching view, thinking about rehabilitation, that readiness, we're going to assess that readiness to exercise. And I would suggest that we can be starting some of that passive activity from immediate admission, moving through those activities, repeating our risk assessment on an intervention-led basis. Even within a treatment, we might need to continually reassess or adjust and adapt what we're doing. But again, ultimately, what we're hoping to do is optimize that functional ability of the patient, getting in early intervention to hopefully optimize the patient for their ultimate discharge. Out of interest, I put together Tony's journey. And you can see, a lot of you will know this already, but we're not talking about a couple of days here and there at each stage. It was 25 days from admission to that point where the decision was made to tracheostomize Tony. So that's nearly 3 weeks of ventilation. When we were thinking back to that early versus late tracheostomy, he had a rocky stay, and I don't think it could have been achieved any earlier than that. Another fortnight until going through use of those adjuncts and progression through tracheostomy weaning to that point of decannulation. So another 2 weeks within an HDU environment looking at steady progression to decannulate. He actually was only then in critical care for another 2 days and was able to step out from there to our neuroscience ward, where he stayed for another number of weeks, having daily input from the broad AHP team before being stepped out to specialist rehab, where he continues his input. So in conclusion, I've literally given you a whistle-stop tour of our experience locally, or my experience of working with this patient group. I think from what I've read and what I've done clinically, we are all finding our own way, and I'd be very happy to either hear now from anybody who wants to compare what we're doing with maybe with your local practice, or ultimately to touch base either email or on socials about any differences in practice. But ultimately, we're all still learning, and it's all still a bit controversial. So thank you for listening. Thank you for your time. And I'm going to hand back to Aaron.